what Anandadeep informed was an insight to how the real-time understanding of this COVID numbers take place and how government that helps in formulating policies and monitoring and all those that we look for lockdown or unlock processes. It's an honor to have Anand with us. The reason I'm telling this, that I also happen to be his batchmate. So it's
Rakesh,
always
please,
an honor to host a same batch friend.
Thank you.
Anandadeep is associated with the University of Birmingham as an associate professor. He has done his PhD in applied mathematics from Canfield University, UK, and holds fellowship from Princeton University and Rutgers University, USA. Without taking much time, I would now invite Anand to just start it. Over to you, Anand.
Yeah, thanks very much. Thanks for your kind introduction. Yeah. Before I start, I'll just now share the screen. I think we have tried it once. I share the screen. Then I go PowerPoint. Can you see?
Not yet.
Share content screen. Broadcast one. Yeah, you are seeing, right?
Yes.
Can you see now?
Right.
Yeah.
Yes. Yeah, perfect. Okay, couple of thanks before I start. I just want to thank the Praktani Adda group. I think they were incredibly quick and responding. Sorry if I had messaged a bit too much. Thanks to Rahul Shubham for the super poster. The poster speaks more than what the presentation might be. Thanks, Ritesh Bhaiya, Rishi, and Rahul, and of course, Abhijita. Thanks to all. Okay, so I will present how mathematics was involved in COVID-19 transmission projection. And so what I'm going to present today is the work with which I was associated with the government of UK. So this is a joint work between University of Birmingham and NIHR, which is National Institute of Health Research, and how we fed the government of UK. And we were not the only team to feed, but since we are in one of the biggest areas of UK Midlands, so how our things were taken into consideration when policies were built. So whatever slides I'm going to present today, I have taken permission from the government authority body. So I'm not presenting anything which is illegal. However, I will not be presenting everything and data specifically on the Delta variant, but I'm happy to answer questions. In between the presentation, please feel free to stop me. And you can ask any questions. You can just say, hey, Anand, what is this? And I'll be happy. Yeah. So this is the agenda. So I'll go to the desired output. So what I'm going to specifically focus on today is that how we design the model. So what went in designing the model, and hence we started with what we wanted the model to do. So that is very important. So that's the desired output. Then the model itself, designing and the estimation. Then I'm going to show you some real-time application graphs which were presented. I mean, the presentation is almost exactly the same. So you will see what I have presented to the government. And then we will talk about the circuit breakers, how it works, whether it worked. And then we have the vaccine prediction and optimal targeting of vaccine. This is exactly how we proposed how the vaccine program in UK should go. And I'm very proud to say that of all the countries, as far as I know, I think there are about 200 countries in the world right now. UK's vaccination program is the best. Right now, we are 20 plus to 24. That means, you expect others to have at least got one shot, which is incredible. Then I will something about the predicted deaths and the bigger picture. The bigger picture won't be discussed today, but as we had discussed with Ritesh Bhaiya, maybe it is for some other times, for some other session. Okay, so Rahul, I'm clear, audible, right?
Yes, you are.
Rakesh Jha. Yeah, Rakesh.
Yes,
yeah.
yes.
Yeah. I know Rahul as Rakesh Jha. Yeah. So this is ethical consideration. So whatever data I'm going to present was supplied by Chess database. So everything is with University of Birmingham and Public Health of England data. So everything is legal, and I'm an owner of, not owner, I wouldn't say, I'm a shared of this Chess database, so I can use that data for research application. So aim and requirements, this is key. So when we first started developing the model, so we got a call early 2020, and various teams were set up. There was the Imperial Strategic Team group, and there was from West Midlands, there was the Birmingham and the Warwick group. So I was lucky to be a part of the group. So the project was developed through a classical example of design thinking, you know, so it's a collaborative work. So this is what we wanted to do. So we wanted to have a deterministic transmission model. Why deterministic? Because we need to know what's happening. We need to have solid state finite answers. So we need to have a deterministic transition model that will use the real-time data and up-to-date predictions. Also, the model should capture various parameters of the epidemic, and specifically the age-dependent heterogeneities and reduced transmission form and the asymptomatic infections. Now, one question you might directly ask me right now is why age-dependent? Yeah, that is the data feed. So from the data, we got that the earlier infections and earlier deaths which were happening were very much age-related. So there was a vulnerable class. So it was very important for us to take into consideration the age factor. Of course, the team we had, this is a 10-member team with 2 leads. I was one of them, and we had a couple of doctors from critical care consultants. So we knew what we were doing, and the feed was directly from the medical trusts. So also, which was very important, is that when we develop the model should be robust, of course, otherwise it's not consistent and it will give you spurious results. But not only that, the model should be capable of simulating various scenarios so that we can have a prescriptive model, not only a predictive, but a prescriptive. So predictive means we are predicting something, so that's the forecast, but the model should also be prescriptive. So we know that what is going to happen in the future, and based on that, there can be some prescriptions for the government to follow. And I will show you exactly what those prescriptions are in the coming slides. Of course, then, considering the future epidemic outcomes, so the model, we also have to investigate the impact of reducing compliance. So what do you mean by reducing compliance? Relaxation of lockdowns, which UK is right now going through. I think you all must have, I don't know whether you all are aware or not, but we have just delayed our complete relaxation by 4 weeks. And I strongly support that. That is because of the B117.6.1, that is a Delta variant, or you can say the Indian variant. So yeah, and of course, the measure and the way in which the variants are getting transmission of the new variants. So our model should be able to capture those things, and that is how we fed the government. So okay, so let's go to the model design. The model design is pretty simple, to be very frank. So it's a novel compartmental model. It's a mathematical model, and it takes into consideration the transmission of the virus. Very simple, So there are various models available, and we took one of the most logical ones, which is the SEIR model. So yeah. So the SEIR stands for susceptible. So there are So out of the population, there are some people who are susceptible to getting infected. So when you're susceptible, you get into a latent state where you are exposed to the virus. Once you're exposed to the virus, then you enter into the infectious state. And once you're in the infectious state, from there, you can have hospital care or blah, 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 or you can even die. And there you are in the removed state or recovered state. We call it the removed state. So this is one of the models. Some of the other models is the SIR model, where they don't take into consideration the exposed latent state. That's also fine. We took this step because it was easier to lay the assumptions and withdraw the assumptions in order to make the model more rigid and to analyze the various scenarios which the government specifically wanted us to check. So and we added complexity to the model because we had 21 age classes. So why did we have 21 age classes? Because the model was the age class was very, very critical to be included in the model, because the data we got from the NHS is that the initial deaths because of COVID and the hospitalization and the ICU, the initial death, they were very much age related. And with age related also, then you get exposed, because if you are young, you might need to go more, you might want to go out more for exercises. When you are old, you might want to stay back. However, if you are old, then you're more susceptible to get the disease. And we have various care homes and various structures of the healthcare system in UK. So age classification was the key. And more you put age classification, then the more complex the model becomes. So exactly. Why age? Because age was a critical input which we were fed from the NHS, and it was very well taken by us. And we could see that the data is saying that age was the key. And with age, everything was related. So we had to get down into various age classes. Yeah. So apart from the simple I would say the ACR model, which is susceptible, exposed, infectious, and removed, we took into consideration various other parameters. So which were the symptoms, quarantining, and the household status. Now think about it in this way. Suppose I'm susceptible and I get exposed. However, when you get exposed and when you get infected, let's say with the virus, there were not all, because the tests were not there that time in UK. So what happened was very few part of the population, maybe the doctors and the support staff of the key health workers, they were getting tested. Now there were two issues coming up. First, you are not getting tested fully. Now, also, if you are getting tested, then you can also have a false negative or a false positive. So some of them were symptomatic. That means the symptoms were there. And so we named them as detected. So you're getting infected, but you're getting detected from the test. And some of them were asymptomatic. So means you have it, but you're not getting detected. So the infectious state, we had to divide it into two parts. So one was potentially detectable, and the other one was more likely to remain undetected infection. Okay, now ACR has got a limitation, and this was very key. And I will try to briefly explain the limitation and just see, So in the ACR model, so the differential equation which we solve to get the ACR model. So what is a differential equation? So you want to solve, so if let's say function of X or function of Y depends on various parameters, we solve it to see what are the values of Y. Simple as that, So in the ACIR model, what happens is, it's pretty simple. If you set, so you have a household and then you have the surrounding community. If you set the transmission rate to 0 of the surrounding community, so if you set the transmission rate to 0 of the surrounding community, and if your household has one infected person, the ACR normal model will show that still the transmission can happen. So if you are taking this household out from the sample, still the model will say that the transmission can happen. So this is a limitation. The limitation is there because what happens is, suppose in my household, I get the disease and then I transmit that disease to my other family members. So what should happen to me? So there should be a decay in the transmission rate of the first one who gets infected. And then the subsequent, so the initial and the subsequent people who gets infected, they cannot have the same level of transmission, so there has to be a decay in transmission and there has to be an increase in transmission. So the ACR ordinary differential equations don't take that into consideration, So even if you set the parameter as 0 external to the household, they will still say that the transmission is there. Now, if you use this, what's the problem? You are overestimating. Then you might argue that overestimating is good, right? Because you're trying to solve the thing and people will be more restricted. No, but overestimating is not good, because when you do overestimating, all the parameters increases and you might end up doing more things than what is required. Now, it has got a ripple or detrimental effect on other things, the bigger picture when the economy comes into play. So what we did was very simple. So we addressed the limitation by differentiating the SEIR model into first infectious and the subsequent infection. So we did EF, DF, and UF. What is E exposed? D and U are what we discussed, detectable and undetectable. So infection detectable, infection undetectable. So we again subclassified the SCR model in this. Okay, bang. So this is a model, very, very simple model. So what's the model? So we have a susceptible, as we discussed. So part of the population is susceptible. And then the susceptible ones enter into a latent stage, which is the exposed stage. And then from exposed, you get the infectious states. So one is detectable and the other one is undetectable. From the detectable ones, you can be hospitalized, ICU.
Yeah. Nang kuti maral kedane macha.
Hello, Anand.
Hello, can you all hear me?
I can hear you now.
Yeah, I got that. Sorry. Wait, Ritesh, thank you for calling. Wait, I'll quickly. I'm doing from my laptop now. Share screen. Host disable participant sharing screen. Rahul,
Wait.
can you please? Yeah. Sorry, guys.
Please check now.
Okay. Yeah. Share screen. Transmission capture. Yeah, you can see now, right? Okay. Till what point could you hear me?
To be honest, I couldn't hear you from the model one when you were showing the
Anandeep, the framework of the model.
The framework of the model.
Model design, you heard it, right?
Not yet, not really. That was the beginning where it stopped.
Okay. It stopped at the right place.
That was covered.
Yeah, can you hear me now? You can hear me now, right?
Yes, I can. We can.
Yeah, perfect. This is cool. Yeah. Sorry. It's let's claim it on the UK Wi-Fi. Yeah. Okay. So, so the model design. The model we presented was a compartmental mathematical model, and it was essential that we take into consideration the various other things which I have discussed, the aims, requirements, and the future. So the model had to predict what's going to happen. The model had to also.
I'm sorry to intervene. You are hardly audible.
This is crazy. Can you hear me now?
It's clear now.
Yes, clear now.
Can you hear me now?
Yes.
Yep. So yeah, the model which we designed was a simple. So when we go to infectious disease, there are two models which are commonly used. One is an SEIR model. I will go through it again, and the other is an SIR model. So what we do is we stratify the population into four categories. One is susceptible. So there is a population which is susceptible of getting exposed to the disease. Then once you're getting exposed to the disease, you are infected, and then you enter into the removed stage. Okay. And so from the susceptible to the infected state, you enter into a latent state, which is the exposed stage. So I'm old, I'm susceptible to the disease, I get exposed to the disease, then I get infected, and then I get into a stage whether I survive or I don't. Okay, that's removed. So we added complexity to the model by including age classes. Now, you might ask why age? So what happened was the team which was developing this. So there were various teams across UK which were developing this, and since we are in Midlands, Birmingham is the second biggest city of England, anyways. So the University of Birmingham and Warwick collaborated. So there were about 10 people there and 2 leads. I was one of them, and we also had a huge chunk of doctors, critical care consultants. So the feed which we got from them was age played a very, very key role, because the initial number of deaths, hospitalizations, and were very much age dependent. And with age comes a lot of things. You have more, your immune system is a bit not that good. And if you're old, you might be there in the care home, blah, blah, blah. So age was very, very key in taking into consideration. And since you have very many age groups, so the transmission of the disease for a younger person and the transmission of the disease for an older person, they might not be the same. Okay, so we had to include the age classification so that we could answer many questions, and I'll show you exactly how we answer. So yeah, apart from the simple SEIR paradigm, which is susceptible, exposed, infection, and removed, the population was also differentiated
based on the symptoms, quarantining, and household status. Are you with the family? Are you alone? Do you have critical care workers, or various household status? Okay. Okay. Now this is interesting. So initially, when the disease came to UK, we did not have enough test kits. Of course, we did not have, and there were not enough tests done. So what was happening is, suppose out of the whole population, a very few of the population who got infected, or who thought that they got infected, there were some symptoms of cold, fever, taste loss, or something like that, loss of taste. So they were getting tested, and those who were getting tested, it was not necessary that all of them were getting the right result. So some of the symptoms were detectable. So some of the infections were detectable. Some of the infections were not detectable. So we had to take that into consideration. So some of them were symptomatic. So the symptoms were very much there, and some of them did not have the symptoms. So we also had to take that into consideration. Now, but there was another problem with the SEIR model, that has got to do with the fundamental differential equation it solves. So what's a differential equation? To be very frank, if you want to solve a function which is dependent on various parameters, you solve that function. That's a differential equation. So now I'll give you a small example which will help you to understand this in a better way. So suppose, let's consider my household, okay? Now, in my household, suppose I have the disease, sorry, not the disease, I have been infected. So I have a COVID now. So in my household, if I have COVID now, I'm going to spread it to my family members. That is correct, right? However, if you take my household out of the system, so suppose this is a bigger system, this is the population, this is my household. If I take my household out of the system, and that is essentially saying that if I put the environmental as 0, that means there cannot be any transmission of the disease. I put the transmission rate as 0. Okay. However, the original SEI model will always say that there is still a transmission possible because your household has got the disease. Okay. Now this is wrong. Why? Because if you restrict the community, if people cannot go out, there is complete shutdown. So then you can really keep the transmission rate to 0. So SER model does not consider this. So we had to consider we had to consider this. And what did we do? It was very, pardon? Oh, no. So we had to do this. What did we do for this? It's very simple. So what we did was, suppose I have the infection in my household, right? So I'm going to spread it to others. So when I spread it to others, the others which are subsequently infected, I am the first one to get infected, but those who are subsequently infected, so there will be a decay in transmission for me, and there will be a growth in transmission for the subsequent ones. So the transmission rate of the first and the subsequent ones will not be the same. So there has to be a decay component involved. So that is simply that is what exactly we did. So we divided the transmission of our household into 2 states. One was the exposed, D is detectable, U is undetectable, first ones and the subsequent ones. And for the first ones, we included a decay to the whole system. So yeah, bang. So this is the model. It looks pretty simple, and it looks good. So this is the model which we use. So this is the classical SEIR model. And then we had to make a couple of improvements in that. And I will discuss that. I will not discuss the equations here. So we had the susceptible state, which I just illustrated. So a part of the population is susceptible. They get exposed. Once you get exposed, you enter into the infectious state. In the infectious state, you might be detectable. That is, you have the symptoms, you might be undetectable. If you're detectable, then you can go to hospitalize, you can be hospitalized, you can go to ICS, you can be unfortunate, and whatever is the case, all of them lead to the removed state. You are cured, you are discharged, or yeah. Now, the solid lines means we have the simulated data, and the dotted lines means we are getting this data, we are getting the real-time data from the NHS trusts. Now this is very important because this helps us to understand what's going to happen when we when we do the projections, so how overwhelming the hospitals are going to be, so how the healthcare system is going to be burdened. See, one thing you must understand is that UK just postponed their complete lockdown by 4 weeks. I guess I don't know whether you all know it or not, but right now we have postponed, not we, the government has postponed the lockdown by 4 weeks. I'm very happy and I completely support. Now, why did they postpone? This is key. Every policy the government has taken is to protect the healthcare system, because if the healthcare system crashes, then you cannot protect the population, right? So in no way you can let the healthcare system crash. And this is the difference between a country like UK and, let's say, India, where in one country the healthcare system doesn't exist, and here we have a healthcare system which is bound to be protected by whatever way you can, so that it can serve the purpose. So all these protections, all these lockdowns are because we want to protect the healthcare system. We cannot let the healthcare system go so mad that it just lets loose itself and everybody, it gets out of control, And so all these models we developed, this was a strong directive from the government task force, is that the models need to tell us what's going to happen in the regions, and you need to tell us the numbers so that we can identify policies and principles in way to protect the system. And I will show you exact this is a part of the presentation which I had presented, so you will have some graphs here. Okay, so let's go to the model. I will not be going to certain things. I would like to explain. For example, beta BA. So what does it mean? It means transmission. This means transmission rate from age group B to age group A. So there are 21 age group classifications. So age group A to age group B transmission rate. So I'll just some of the things I'll just tell you. So beta BA we have already said. So epsilon, so E is the rate of progression of the disease. Gamma is the recovery rate. Then we have alpha, where we have age dependent symptoms. So younger age groups might have lesser symptoms, visible symptoms or detectable symptoms than the older ones. Then we have alpha, then we have tau. Tau is a relative rate of transmission of a symptomatic person and an asymptomatic person. Now the transmission rates will be different. Why? Simple logic. Because if I have symptoms, I have been detected, so I'm quarantined. Now, suppose I get the disease, but I do not have symptoms, I'm not detectable. What happens? I roam around. I go to shopping in Tesco, and the whole Tesco gets the disease. So the rate of transmission of a symptomatic person will be different from that of a asymptomatic person. So we take that into consideration. Then we have displaying of symptoms, age-related susceptibility. This is a very cool parameter, sigma A. So older age groups will be more susceptible to the disease than the younger ones. That is why you will see why this was extremely critical in circuit breakers. I will discuss that. So, and then you have the household quarantines, which is there. So if you're infected, you have the household quarantine and population size of a given age. So all this data here, I've also stated the sources from which we get the data. So some of them are data from directly from ONS. This is the what should I call, the statistical database of UK. Some of them we fit the data. That means we run simulations of the very little data we have. We run the simulations and we get the data. So what we run is an MCMC process. I will quickly tell what is that. We can forget this slide. This is for just the completeness of the presentation. So these are the various models we had. What should I say? We had estimated. And you can see we had taken various household structures, and so for example, this is the first infection. Then we have the subsequent detectable infections. There's a subsequent detectable infections. Then you have the subsequent undetectable infections. So yeah, this is external infections. So we had taken most of the things into consideration. Now, this was key in understanding the model, in how the model can best represent what's happening. So while developing the model, we had to have the case severity parameters checked. So we had to know whether the model is good enough to understand the severity of what's happening. So we estimated each group, each age group was taken, and we got the data from the hospitals, and all the distributions. We estimated the distributions of the age related susceptibles and the infected ones. So we used independent distributions for the onset of the symptoms. One of the biggest problem which we had in the initial stages, so I'm talking about, this model was developed, I think we got Feb end 2020, but the initial results we started getting from March. One of the biggest problems which happened was we had very few data to match. So this is a classic example where we know something is happening, the model is there. The model, I would say, was super rigid and good. But initially, when we were told by the government to give prescriptions, because the model is a prescriptive model, one of the biggest questions we faced and we had to answer was we were not getting enough data. So since enough data, some of the prescriptions we made were sometimes too loose or sometimes too rigid. Too loose will be a problem. Why? Because maybe the transmission rate will increase, but too rigid will also be a problem. Why? Because you're putting the economy in strain, and UK is currently in severe strain because of this. So that was the initial problem we had. But once we got the data, then we will see how the results matched and government took actions. So that was also a part of the theme, that this is not only a predictive model, that means what is going to happen in the future, but this is also a prescriptive model. So we prescribed that, maybe these are the things which you should do. And the government did in the same lines. So so we took data from various hospitals, and we had to do that. We did it for 10 regions, in UK, we in England. So we covered the whole I would say spectrum of England. So we fit the model for 10 UK regions, independently, region by region, and so a lot of data was there. So we performed a simple Metropolis Hastings MCMC algorithm. MCMC is a Markov chain Monte Carlo. It's the same algorithm. Not the same algorithm, but Google Page Rank also uses MCMC. It's a very powerful. It's one of the top 10 powerful algorithms, I would say, MCMC algorithm. And we had we took a Poisson distribution. You might ask, why Poisson? Because it's a count distribution. Very simple. So the logic, because it's a count distribution, so we took a Poisson distribution for new hospitals, hospital bed occupancy, ICU bed occupancy, deaths. Then for B117, this is the Kent variant, pillar 2 testing, and the serology when available. So we took almost every possible which the doctors felt were important in understanding how the COVID spread is happening or the COVID transmission is happening. So how many times did we simulate? We had burnt it for around 250,000 times first, and then we reburnt it for another 250,000 times. So 500,000 times the simulations ran for each postcode for each 10 regions, so that we get rigid, robust results in prescribing what the government should be acting upon. So we did a lot of simulations. So there were interventions we had to take into consideration. So example, the mixing matrix. What's a mixing matrix? When one household mixes with another household, when one age group mixes with another age group. Can this happen? This happens every day. If you have kids in the house, the ages are different. Even in the house, the ages are different. If your grandparents stay, if you're in care homes, then the age. So we had to take the mixing algorithm of, not algorithm, the mixing matrix for the household transmission. Then we also took the implications of various short-term lockdown measures. Then we took the age-dependent relaxation of lockdown measures. So, earlier the seniors were restricted that they cannot leave, but middle order age groups, you can leave and go for exercises. So we took that into consideration. Then there were full relaxations, and then there were region-based lockdown measures. For example, Scotland specifically had a bit more rigid than, I would say, England. Yeah. A quick check, Ritesh Bhai and Rakesh, am I audible?
Yes, you are.
Yeah. Any questions so far? Or is it super boring? You can tell me if it's super boring. Then I will talk about sun and the beach or something. Yeah.
Just a layman question from my side, before just in the last slide when you talk about the poison metrics and all those things. So obviously we don't understand, as a common man, we don't have that understanding. So if you could just elaborate very briefly what that metrics mean and why it was important to take that into consideration.
Yeah, Poisson distribution is if it's a count distribution. So in a particular given frame of time, if you want to count how many hospitalizations are happening for a particular age group, so since from the very beginning, we saw that senior, when the first wave came, so the seniors were getting more infected, right? The senior age group was getting more infected, and they were the one who were facing more unfortunate deaths. So we had to take a distribution where we could count the number, where we could count what's happening in a particular restricted time, the number of hospitalizations, number of deaths. So the population data we got, so we fitted that into a Poisson distribution so that it can be fitted into the model. Yeah, so age classification was very important. And what is this age mixing matrix? So age mixing matrix is very simple. So you have age group A and age group B, right? What is the percentage that they are going to mix? Because if there is a 70% chance that they are going to mix, that means the transmission will be high. Whereas if the mixing of, let's say, an infant and a 70-year-old is only 0.2%, then the transmission will be very less. Yeah. So we had to build a matrix where we had the various age groups, and we had to see how much is the mixing going to happen. Because based on the mixing which is going to happen, the transmission is also going to follow that path, isn't it? So if I'm going to mix with my kids in school, so kids are going to get it. And if I'm mixing on a regular basis, I'm going to get it. Yeah. However, if the kids in school and let's say a grandparent in the care home, they are not going to mix because the government has said that you cannot mix. Right? So the weightage will be low, and the transmission of the kid giving the disease to the old age home will be less. Okay. Yeah, it's simple as that. Yeah, because what was happening is, I will show you the graphs. It will be clear that when the lockdown measures were brought in this country, it was very essential that we have a clear age classification, because we found that the senior age group were very, very susceptible to the coronavirus in the first wave. Yeah. So because they are immunocompromised and whatever they might have, diabetes, more comorbidities, all those things. So it was very important that we classify the age groups and we see how much these age groups are mixing and how much the transmission is happening from one age group to another age group. A classic example is, if you see, the key priority of UK, and which I strongly support, and I'm very happy that they did this, was the key priority of UK was opening of the schools. Yeah. But if you see in India, for example, I get some feeds from Delhi from my friends, the shopping malls are open, but the schools are closed for the last 1.5 years. There can be various arguments, but in UK, we wanted to open the schools. And how could we do that? Based on these models, because we saw that the susceptible group and the kids getting infected and they becoming the super spreaders, it is not a click match that these guys are going to spread the virus to the susceptible group. So you open the schools, let the kids don't feel the psychological impact. It is very important here, the psychological impact, what's happened to the kids. So you open the schools, but you keep the malls closed. The carers are in the old homes. So even if they spread, they are spreading to 45, 50, 55 age group. So these susceptible groups gets shielded. Yeah. Any questions, please? Please ask. Yeah.
Ananda, one question.
Yeah. Who? Yeah. Yeah.
Myself, Amitabh Acharya from Delhi.
Oh, Amitabh. Tell me.
Just one question. You said it is transmitting from 1 to A to B, right?
Yeah. B to A. Beta B to A. Yeah.
Keeping all factors common, how can you say whether it will accelerate or it will be decaying? The factor of germ as a common man, right? When it is transmitted, whether it will accelerate on the subject or it will decelerate. That is my whole question. Is there any...
Yeah. Good question. So see, what we did was, suppose age group B transmits it to age group A. Clear? Now, if age group B transmits it to age group A, then it is very important to know how age group A is then related to the other age groups. Okay. Now, based on this transmission, we will see how A is going to transmit it to others. Now, the decay which you are saying is, so if I am the first infected, and when I am transmitting it to the subsequent ones, my transmission level is going to decay. Why? Because I'm developing the antibodies. I'm already infected. So my transmission is going to decay. Whereas the subsequent ones whom I have infected, it is going to increase a bit. Then again, they are going to decay. And when it is increasing, it is spreading it to another age group or to another person in the household. Okay. Now, if you want to, if your question is, does the transmission rate of a particular age group vary across? That means transmission rate of A, is transmission rate of age group A different from transmission rate of age group B? Yes, we have taken that into consideration. If you also think that, you know, if the transmission rate of a detectable person, that means I'm infected and I'm also been detected that I'm infected. That means I'm symptomatic. So the transmission rate of a symptomatic person is also different from the transmission rate of a non-symptomatic person. You know, so we will see that phi, you know, impact of adherence of restrict.
Okay, thank you.
You know, rate of progression of infectious disease is there. Then so we had taken all the parameters to see how this transmission rate has changed. Now, how did we come up with the parameter estimation? So what we did was, initially, as I said, the data was so less that we had to simulate and generate a lot of data ourselves, so that from the very little data we have, we can get an answer. And that's why actually we use this Metropolis Hastings MCMC. So what does Metropolis Hastings MCMC does is, so it's a very simple algorithm. So what it does is, it helps us to take a sample out from a population, and it maintains the distribution of the let's not use the word distribution. It maintains the same parameters of the sample and the population. Otherwise, it wouldn't have been possible. So the population is so less that you cannot pick a sample. If you pick a sample, that's a population itself. Okay. So what this algorithm does is, it expands the population. Then it helps us to take a sample, and the parameters of the sample and the population is same, so that you can generalize. So then you estimate on the sample and you generalize it to the population. Am I a bit clear?
Yeah, thank you. Thank you.
Yeah. Good. Thank you for asking. Guys, please, I mean, whatever, feel free. I should be able to answer. If I'm not, I'll email you the answer in a day.
Hey, Anand, this is Vinod.
Yeah.
I'm Ritesh, batchmate. I have a query. A query. You are using that MC, that algorithm to create a population. So it means that you are predicting the population, and based on that prediction of the population, you are building a model. Don't you think accuracy will vary? It will be like on the predicted value, again predicting something.
Yeah. Oh, so super good question. So, you know, so initially, I think I just said a couple of minutes back that initially we had so much less data that the initial forecasting of what we were doing were not accurate. So either it was too strong, too rigid, that means you lock it down for, let's say, 14 months, or it was too loose. So as and when we got more data, so what started happening is we were then not forecasting the population. Then it was very easy for us to pick the sample from the population and then just focus on the sample and put it on the population. But initially, when the data was less, we were not able to pick a sample. So let's say if you give me 5 guys who are infected and 2 guys who are not infected, and if you tell me to tell what's going to happen to a population of, let's say, 70,000 people, I just cannot run any estimation. So what we had to do is, the initial data we got, we had to expand it. And when we expanded it, we got its parameters, we got its distributions, what is going to happen in the future. And from there, we picked a sample. Yeah. And then we worked on this sample. But as and when we got more data, then we were not expanding the population. Then we got it after the first wave, really, after January, March, April, May. After May, from May, we got so much data that our sample implications were good enough to have a prescriptive result. But initially, as you correctly said, Vinodha, that there was a bit of mismatch, and the model accuracy was not that good, and hence you would see that initially UK struggled a lot. You saw that, right? In the first wave, UK struggled a lot, and we could not protect the healthcare system. I would again say, all the measures taken by UK is to protect the healthcare system. You protect the healthcare system, you protect the population. So you don't protect the population, you protect the healthcare. Population is a consequence of the healthcare, so you protect the healthcare system. So initially, you would have seen that UK was so miserable, and India was so great. I mean, we did not lock the borders, we did not do anything, and we were just all over the place, and all the models were not able to predict. But slowly, when the models were able to predict, and we get the prescriptions we did it for 10 regions, but our main region was Midlands, where we and you will see how government used our things. I'm going to present the results right now so that it helps.
I'm eager to see that result and how it varied from initially till now.
I'll show you. Thanks for the questions. So I've spoken a lot of I think boring stuff. So next, let's see some results, which we fed to the government, and bang, prediction through time. So here, see, we had simulated the date. So you can see from August till 14 May. So we have simulated, and you can see how the various waves, hospital admissions, it came. This was the bad time during 28th March. Our data was so low that we just didn't know what we were doing. Then there were lockdown measures. This was a restrictive and a rigid lockdown. It was something like, let's lock it down. We don't have anything. Let's lock it down, and then we work on the models, and then we prescribe something later. So there was a rigid lockdown mode. And then there were some, again, we started relaxing the norms. It went up. The second wave happened, which was very much projected because of early restrictions, which were open during Christmas. Why were it open? You had to open it. I mean, people were crazy. It was Christmas. Government was like, so people went into the mode like, who cares what Corona is? I want to drink beer. So all this happens, and there was a second lockdown, and there were severe restrictions. I'll show you some other results, which will be a bit more interesting. See, clinical case projections. This is cool. So deaths in thousands, you see, it started in March. Controls, no control. So these are our model predictions, so controls, no control. So if you do control, so you control it. If you are not doing any control, so you can see that the waves are coming and going. And you can see a huge a bump here, so control, if you do control, then it is very easy to keep it down. Similarly, ICU occupancy. Again, why deaths? Why ICU occupancy? More than deaths, it was important that what we are doing with the ICU occupancy. Again, you cannot let the healthcare system submerge with so many infected persons that it cannot deal with it. I'll give you a small example. As opposed to India, what is happening in India is, if someone gets a symptom, you run to the hospital, you take a bed. If you're a rich guy, if you have got power, if you know Sonu Sood, you get a bed and you stay. What are you doing? You're blocking a bed. You don't need the hospitalization. You need no nothing. You can stay at home and then you can recover, but no. What is happening in UK? You get infected, you stay at home. You're not able to breathe, you stay at home. You are really not able to breathe and you're going to die, you call 911. Ambulance will come. The paramedics are going to see what they can do. So you are still there at your home. The paramedics will come and work on it. They will revive your oxygen level. They leave. You are still at home. Again, you cannot breathe. Again, call the ambulance. They will again come and do that. So you cannot go to the hospital in UK unless and until the ambulance comes and says, hey, listen, now you need to go to the hospital because we cannot mend you here. Do you see the difference? So in one case, and why? Because we had 1/3 of the ICU beds as Germany. We had 1/4 of the ventilators as Germany. Now, ventilator is a support system. It's not even a medication. So, but the key aim of the government of UK was to protect and let the healthcare survive. Because if the healthcare doesn't, it won't work. So our predictions were telling you that you need to control. Now, see, this is the assessment of the age-based shielding. Now, this is one of the most important graphs from where the government came up with the age-based lockdown. And I'm going to tell you that. See, let's look at the first graph during lockdown. Yeah, so during lockdown, if you lock it down from 45 up, that means if you're 45 years or more, you cannot go out. So you lock it down for 45 age group. So if you lock it down for 45 age group, you will see that the number of deaths are very less, isn't it? 50, number of deaths are more. So if you lock it down from 75 onwards, that means people who are till 75, you can go out. But if you are beyond 75, then you got to stay at home. Then the number of deaths are very high. Yeah. Now, after lockdown, what we see is a reverse effect. Now, after lockdown, if you restrict it to 45, then there is a chance that the number of deaths are going to increase after lockdown. Why? Because when you restrict it to 45, then after the lockdown, all categories will go out. Now, these categories are more susceptible. Why? Because they are more aged. So their what is that called? Immune system is compromised. So if you lock it down from 45 and number of deaths are less, but after lockdown, if you lock it down at 45, then the number of deaths are high. So the point where we reached the best was somewhere around 65. So 65 was the cutoff. This was one of the best things which our team found out, and the government took it immediately. So 65 was the cutoff rate. So you can go for exercise once a day if you're below 65. You can't if you're above 65. You have to be at home. So age-based and all these simulations which we did, all age groups had different transmission rate. So you see everywhere ICU occupancy. If nobody can come out of their house if they are more than 45 years of age, the ICU occupancy is the least. However, after lockdown, if this is the case, then all these guys, when these guys 45 and more come out of their house, they are more susceptible. Why? Because they're aged, they get more infected, and hence there is more ICU occupancy. Again, the best age was 60-65. Okay, so this graph, the combined graphs, was very key to understand at what age the government needs to take the cutoff point. So if you are 65, can't. If you're 65, you can still go once or twice a day, whatever the rules and restrictions are. So that was one of the key things. Guys, okay? Are you all fine? Yeah.
We are.
Yeah, good.
Completely clued in. Thank you.
Okay. Okay. So the next is the circuit breaker. We heard a lot about circuit breakers. Curfew after 11 a.m. so that the circuit breaker is there. And so what is a circuit breaker? Okay. So we did a hell lot of simulations on circuit breaking, and it's pretty cool. You will see why government was bent on circuit breakers. Okay. So what is a circuit breaker? Circuit breaker takes you from regime of exponential growth. So you're growing boom to regime of exponential decay. So you're growing regime of exponential growth. Circuit breaker, you go to a regime of exponential decay. So you delay or you stop the propagation of the transmission of the disease. Or you can also say that so regime of exponential growth, halt it, and it gets back in time. That means you stop the propagation and you pull it back a bit more. So you take your propagation rate to a delay. That means, you pull it back. Okay. So it can also be called as back in time. So effectively taking the epidemic one step earlier. So before peak. So we are in the peak, circuit breaker, you go before peak where the deaths and ICU occupancy is less. Okay. So that's why we did circuit breakers, and I'll show you some graphs which we presented. Back in time. Why do I call it back in time? Very simple. See, this is the propagation rate, let's say. So we are going up. Circuit breaker at this point, we fall down. Now, when we fall down, this is nothing but something in the history. See, this is nothing but something in the history. Okay? So we are not killing the disease, but what we are doing is we are holding, we are stopping the time space and we are putting it back. So we go up, circuit break. It starts from here. So we are going back. So we are going back in time. So circuit breaker works. Why? Well, it's always better to go back in time where the peak was not there, where the hospitalizations were not that much, where the deaths were not that much. What does it help? It helps the government to think something. You buy time to think. So one of the biggest implications of circuit breaker is it allows the government time and space to think what to do. As simple as that. Is a circuit breaker working? Yes. Can we have repeated circuit breakers? Maybe. And what's happening? So what was happening during this time? So where is the cursor? Yeah. So we are here. You come here, you go here. So what was happening in this time when we are attending the peak? What's happening? What's going wrong? So it allows the government to have some time and space to think. So see, we added complexities, of course. We had to add complexities. So we had circuit breakers for 7 days, 10 days, etc. And we calculated the number of infectious cases in London. We had this for all countries, not countries, all cities, all major cities. Birmingham was, of course, there. So we had epidemic doubles every 14 days. During this phase, the epidemic was doubling in every 10 days, So we could see that how the epidemic or how the transmission is progressing and how it is, at what rate it is progressing. So when you do the circuit breaker, so at this point, you do the circuit breaker, you go back so much back. So as if you're again starting at what was happening a couple of months back, so circuit breaker really, really works. Now we have to see breaker halves every 20 days, halves every 10 days, halves every 7 days, so depending on the length of time you're doing the lockdown or restrictives. Now these are known as NPIs. What is NPIs? Non-pharmaceutical interventions. That means we have not come into vaccines yet. We will do vaccine projections in a minute. So these circuit breakers are when there are no vaccines. Okay, so these circuit breakers are happening when we have NPIs, non-pharmaceutical intervention. So circuit breaker is an NPI, non-pharmaceutical intervention. What's a pharmaceutical intervention? Classic example is vaccine. Yeah. So if we have a circuit breaker for, let's say, halves every 20 days. So if you do a circuit breaker for 20, it will reduce the epidemic progression by half. Cool. Okay. Now, once it reduces, you are giving the government and you're giving the healthcare system some space to breathe and time to think and get ready for the next one. Why ready for the next one? Because you cannot keep it locked down. It has got ripple effect, So we cannot have a continuous lockdown. But yeah, you break the circuit, take it back, have some time, and think what we should do next. Increase hospital capacity, alter, tweak the age group classifications, close schools, open schools, all those things. Yeah. So, simple theory. This is just for an explanation. So what happens in the circuit breaker? Very, very simple. Exponential growth, exponential decay, again exponential growth. Why exponential decay? Circuit breaker, lockdown, you go down. Why exponential growth? Again, it opens up and you get a again bang, you go up. There is infection, right? It depends on the duration. You see that the duration is there, so it depends a lot on the duration of what's happening. R is the growth, X is the susceptibility rate. At what rate are you susceptible of getting the disease? So duration is key. So you will see that duration of the lockdown is key. Now see, these are some temporal graphs which we produced, and so S is the relative strength, or it's a susceptibility rate, okay, and R is the propagation rate. So we did it for the European lockdown, April lockdown, June lockdown, August lockdown, and as I illustrated earlier, so why we do circuit breaker? You give the government some breathing space. What should be done next? And so circuit breakers were introduced, of course, in UK, and we saw that the circuit breaker that works best is when the susceptible rate is 0. See, S is equal to 0. So growth rate can be 1. This is a propagation rate. But if the susceptibility rate is 0, you don't have much problem. That means lockdown, quarantine. So that will have a reverse impact on R, and the R itself will come down. So yeah. This is the age structured full model. So we did it for all ages here. So how each and every age is going to impact with the circuit breakers, and which was good point is that it works for all ages. So irrespective of what age band you are, it is going to work. And the reason is pretty simple, because there is the age mixing matrix. So one age group mixes with another age group. If you lock it down, this cannot mix. And if it had mixed, for example, in the household, if it's mixing, it's stable, it's constant. So it does not propagate further. So I think circuit breakers worked extremely well. And in one of the situations last year, we prescribed the government to put the circuit breaker, which coincided with the half-term break of the school. So if the circuit breaker coincides with the half-term break of the school, the lockdown period extends. If the lockdown period extends, and it was extremely beneficial. Now, why was that critical? Because if it's a half-term period, that means the kids are at home. That's the time when you go for holidays, vacations. So you got to match the circuit breaker with the half term. So if the circuit breaker is with the half term, that means you put in restrictions when the schools are closed, and it is bound to have a positive effect. And it had a tremendous positive impact. Okay. So this was all done prior to. This is the presentation I presented right now till this point. This was presented somewhere around in March, April. There was a series of presentations we presented, but then the vaccine predictions came in, and we were following what's going to happen. So what is the risk? So what is the whole risk of this presentation? Not presentation. So what is the whole risk of talking about these things or modeling is COVID mortality, death. As simple as that, and the first thing we had to do is we had to have a death forecast. So population size of England, and we saw a number of deaths which are happening per 1,000. So we had a death forecast, and what we found out was that risk of death is monotonic with age. So again, importance of age was very, very important. Vaccines are imperfect. So the group which we were working, the group got expanded in the month of July. In the month of July, where we were tagged with the Oxford group. Why we were tagged with the Oxford group? Because of AstraZeneca, of course. So vaccines are imperfect, unprotected. You get the first dose, you get 60 to 70% protected. You get the second dose, get 90% protected. So just go and get the vaccine until and unless the GP says no, your local doctor says no. So the efficacy rate is less than 100%. Now, what I'm going to present next is very important. So the action of the vaccine. So this we had to consider in model building. So what happens? So if you get a vaccine, the vaccine can have 4 possible actions. Okay. First is infection prevention. So partially prevent infection and therefore reduce the spread. Second is disease blocking, less symptoms in vaccinated individuals. I've also presented the data from some of the vaccines. Transmission blocking may reduce onward transmission and those who are from those who are infected. So this is the best thing that can happen, transmission blocking. And severity reduction. So even if you have it, then you don't die. You recover well. Okay, so these are the four possible actions a vaccine can have, and these are the four possible things which we considered while predicting how the vaccine program in UK should go, and how to start it, when to start it, from where to start it, which age group to start it, and everything. There were some other studies which went parallel. Those are known as the uptake studies. I think those couple of studies just got published. My uptake studies, those were based on vaccine hesitancy and the ethnic classes, how they are reacting in getting the vaccine. So optimal targeting of vaccine, this was a key project, and this was very important. So when the government was about to roll out, and there was, of course, you don't get vaccine for everyone because vaccine is very precious. So we considered an optimal ordering of targeting vaccine. So we had to optimize to generate the greatest reduction in the deaths. As simple as that. Why? Because the risk is death. So we had to have an optimal order of targeting vaccine for the population to generate a greatest reduction in death for each dose of vaccine. Very simple. You might not have both the doses, you can have only single dose, but we need to reduce the mortality. For vaccines that block transmission when the R is kept relatively low, so our aim was that it should be transmission blocking, so it reduces the transmission, and we need to see how while blocking transmission it also reduces the mortality rate. So we came up with age-based strategies for various age groups and the risks involved for targets over 80s, and we saw that the age-based classification and the age-based risk classification were far better than randomly vaccinating everyone. So, what do you mean by randomly vaccinating? Randomly vaccination means you have a vaccination center and walk in. So whoever comes, they get a vaccine, first dose. So whoever comes, get a first dose vaccine. Against age-based, that means you have a vaccine center. You cannot go. The GP will call you if you fall into that particular age group. Okay, so we ran two models to see which one is better. Whether everyone should go, whoever comes gets it, or the other one. In this scenario, we had simulated about for 20 million population, and we saw that we are going to have the second wave. So with the amount of vaccines we had in place, and knowing the fact that age-based vaccination is much better than random vaccination, that is, you just go and get it, still we cannot reach the target of 20 million, and we are going to have a second wave. And we predicted it in last week of September. It hit at around exactly that time, and we had our second wave was very bad. It was actually worse than India, to be very frank. So we had the second wave, and but still, then our vaccination programs took it up, and herd immunity. Herd immunity is population immunity, and can herd immunity be achieved in UK with the current rate of vaccination? The answer is pretty no. So you see that herd immunity. So if the vaccination is 85% infection prevention, 85%. Then you will see that the reproductive number is somewhere here. You see. So herd immunity is very, very difficult to achieve. Everybody needs to get the second dose, and everybody should get the vaccine. That means there should not be any hesitancy. There are some people who have yet not taken the vaccine in UK, and because of which the Delta variant is still there in pockets of Manchester, specifically Bolton, in Leicester, where there is the Asian community a bit more. So, so herd immunity is difficult to achieve unless and until the vaccination program is super strong. I mean, everybody gets it, irrespective of what you think, what you are. You need to get the vaccine unless and until you're prescribed by the doctor not to get it, and at a quick rate, So the higher R value is because of the Kent and the Delta variant. There is also another variant, which is the B116.2, that is the Kappa variant, the South African variant, but it is yet to have any super thing in UK. So we have done just a couple of simulations and we have stopped it. But Delta, yeah, we are going on that. So we see that if there is no infection prevention, if the vaccine cannot prevent infection, so even if you take first dose, second dose, phase 2, it doesn't matter. So we are thinking that the current vaccination is 85%, which is actually, and working on that. Yeah, it's happening. So interaction of NPIs and vaccine, this was the last stage. NPI stands for non-pharmaceutical interventions and vaccines. So lockdown and vaccines, because after November, 25th November, the vaccination program took place, and it started with mass from Jan. But we started having two things happening now: lockdown and vaccination. Don't forget that UK was under lockdown from October 2020 to April 2021. So we were in a huge lockdown phase with vaccination going on, and hence we are in one of the best places right now can be in terms of the pandemic spread. So the next step was to analyze the interventions, lockdowns, and when the vaccination comes into play. So roll out about 2.5 million doses a week right now we are having. Uptake is 95% in over 80s, which is extremely good. So 95% of the population over 80s has got it. 85% for 50s to 79, 70% for 18 to 49. And right now the vaccination for UK is going, I think it is for 20 to 24. That means the above has almost got it, which is good. Infectious protections, we did the simulation. We still take it at 85%. That's why I've highlighted it, because that is what Oxford group told us, which I also believe is true. And efficacy against disease is 70% first dose, 88% second dose. If you see my slide, I had put 60 to 70 and 90 here. However, efficacy, we are doing it as 70% of first dose and 80% second dose. Why? Based on data and simulation. So we are not taking the extreme limit, but we are taking which is more likely going to be the case, and which is the case. So we see this is a great graph which we produced, and this was directly taken. See, relaxation of all controls in April. You leave all relaxations in April, disastrous. That is what we said. Why? See, NPIs means we are having lockdowns, no controls. See, third wave is already there. Hospital admissions, no controls. Can you imagine? This is not happening right now. Right now we are in June, right? NHS overwhelmed, shut down everything. So disastrous. So this is what we said, that you cannot lift everything in April. Just don't do it, please. Relax all controls in December. Not recommendable. Why? You can again see the deaths and the hospitalization rates. Hospitalization rate for me is more important than deaths, because hospitalization and ICU occupancy puts NHS into much more stress than deaths, which can also happen in care homes and at homes. So yeah. So this was some of the. So this is what we recommended: gradual release from Feb. So you release gradual release from Feb. So see, the shaded portion is a gradual release. So you start relaxing, 14-month relaxation time. So if you release gradually from Feb, which is happening, and as you might know that we have again extended it to 4 weeks. So because of gradual release from what we recommended, which was rightly considered and which was recommended by all groups, Imperial Group also said that we could keep NHS on a very, very healthy state right now. And yeah, that is what is happening. And then we had the predicted deaths, so NPI strength, the shaded portion is the NPI strength. So the predicted deaths will of course start increasing if you start reducing the lockdowns abruptly or suddenly from April, and you don't go for a gradual one. In each of the cases, we have again taken 85% infection preventions. All the graphs are there for 85%, 0%, but we still believe that this is the one. The Oxford group has time and again confirmed about the 85%, and we strongly believe in what they're doing. So that is it, basically. And now what's the bigger picture? The bigger picture is, this is only a part of it. The bigger picture is when the epidemiology meets economics, which we are working on several things. And so what's the obvious question? Why don't we find an optimal solution? So much is happening. There is epidemiology. We have the models. We have so many things. So why don't we know what we should do to keep the economy going? So the obvious question is very simple. Why don't we find an optimal solution? But so what's the answer? Why don't we have it? Because we don't have an objective function. So what do we want to do? We want to control deaths. We want to see the GDP growing. We want to see exports and exports growing, imports reducing. So what do we want to do? The objective function is really, really not there. And so this is the optimal behavior. This is not in this session for sure. I think Ritesh Bhaiya had a word with me. Maybe we will conduct another session for this. Now, to answer this question, so before you all can ask me any question you want, is it is quite difficult to solve the epidemiology meets economics in just putting an objective equation like maximize profit, maximize GDP output, maximize revenues. No, I just don't think that is a fair way to approach this problem. We have been working on this problem, but there is a better way in which we are right now focused in. So if you want to answer this question, there are various parameters which comes into play. What are those parameters? Government interventions, first. Second, healthcare sector outputs, healthcare sector inputs, labor force economics. So, and what one player does with respect to another player. So the best way to approach this problem is game theory. So we are right now working on mean field game theory dynamics, where all government interventions are coming. Now, some of the interventions are independent. You just cannot say what is happening. So the intervention is coming based on that. The others are reacting. And we might be able to see how the economic recovery trajectory might look like. For me, it's going to be a long half V-shaped, but we will see what and maybe we'll discuss. Oh, thank you. And thank you for your patience. I hope it was not super boring or super irrelevant. And thanks. Questions? Yeah. Thank you.
That was great, Anand. While I take up questions from others, obviously, I think the first question has already been asked, and that's very pertinent, like all of us would like to know. Abhishek, why don't you go unmute yourself and ask the question yourself? Abhishek?
Hello.
Yes, please. Yeah. Hi.
Hi,
Hi,
can
Abhishek.
you hear me?
Yes, please. Yeah. Thank you.
Yeah, I just wanted to ask regarding the third wave, because I think the third wave has already started in the UK. So how is it going to be in UK, and what would be the Indian scenario? Means, what do you think? How would it go in India?
Okay. Yeah, I will not be saying the data because it's not allowed for me to do that. But in UK, I think the media reports, the UK General House media reports did not ever say that we are in a third wave, which we are not currently. So we do not have a third wave right now. We are relaxing the economy from 19th. It got postponed, right? So from 19th July, we are relaxing the economy, I think in full way. So we are currently not in the third wave. We are a bit concerned about the Delta variant, which is also commonly known as Indian variant. The transmission rate is high. However, we do not have enough data to say that how high the transmission rate is. Some reports I saw in the media, especially Times of India, which said that the 50% higher or something. That's not true. No. So we do not have the data to say how high the transmission rate is, but it's higher. However, even though it is higher, it is not more fatal, and all the vaccines, irrespective of Pfizer, AstraZeneca, and Moderna, which are currently in rollout in UK, they tackle it. So most of this transmission happening because of the Delta in UK is because are happening in pockets where the Asian population is high, and those population have not taken the vaccination due to various reasons, which are extremely. So apart from that, I don't see any wave now. However, to answer your question, Abhishek, there is a projected wave in September, third week of September in UK. There is a projected rate, and that is because since we are opening up everything, and the Delta variant is there, and we expect the Kappa variant, which is the dangerous one, which is actually the South African variant, it might get induced. So there might be a visible third wave in the UK. We had also conducted that study in Liverpool, where we had conducted what happens maskless discotheque. I think it was So if you have a maskless discotheque, the transmission achieved was equal to if you go to a shopping mall. But still, the prescription is not to go maskless. So in UK, you can roam around maskless, but if you want to enter into a shop, you need to wear a mask. And rightly done. So no third wave right now in UK. September mid, there is a projected third wave. However, circuit breakers and restrictions will come into place, and that is more because since everything is opening, it is bound to spread. So yeah, and but the good news is by September, UK 85% of the population who have taken it will be second dose vaccinated. So we will be in a very good situation. Talking about India. Initially, I was when the second wave came in Feb and all, I was a bit involved, but then I withdrew myself because of various reasons. And some of the reasons are, I don't want to discuss, but some of the reasons are, you do something and people don't. People say, if they come and say that, oh, we know this, but then if you know this, you take the necessary actions. You don't take the necessary actions, then don't. I'm not interested in that thing. In India, I think there are many factors in India. See, India is an unstructured economy, so it is very difficult for India. So in India, you cannot take just household. So example, for the model we did for India, and we fed it to various sectors, including government, we had taken couple of subsectors. So we have the migrant population, we have the rural population, we have the urban population, we have the migrant population, from the rural population to the urban population, and from the urban population to the rural population who are going because of job factors. Then we have the schools are not opening. Population density, however, population density of UK and India doesn't vary too much. However, the population awareness varies a lot. I'm not saying that, I mean, in UK also nobody listens to anybody, but still there's a difference. And then you have difference in healthcare sector. UK has a stable healthcare sector. Indian healthcare sector, I don't want to talk about it. Dr. Gupta's lab on April 2020 proved that the Kent variant is because of plasma therapy. All over the world, everybody stopped it. UK was the first to ban it, of course. Recovery studies stopped it. Dr. Gupta's lab stopped it. Everybody stopped it. And India, you are going after plasma therapy. Actually, you are generating more variants. The lobbying is so high. I just don't understand. And it's incredible. And few days back, they have actually stopped it. Actually, I also wrote in the group, it doesn't matter whether you do plasma. It's a placebo effect. The people are minting money. So there are so many things which happens. It's very, very difficult to control. The second is, the economic status of India is so much different to UK because of the sheer population and unstructuredness. You cannot have frequent, continuous circuit breakers. It takes a pretty bad impact. For example, in UK, you had the furlough scheme, the job retention scheme, which is nothing but converting private debt to public debt, which won't be helpful in increasing the GDP of the economy, but which will help in not letting your country sink, whereas it will have a detrimental effect on the growth of the country, but not letting our country sink. Yeah, I don't buy. I'm not in a super support of this because many people have made a lot of money out of it. Big institutions like big universities, but still. So there are various phases. As far as India is concerned, I can tell you about the last projection. So in India, we do not do by the curve is going down or the curve is going up. That's completely wrong. And that's only to satisfy people who read that, yeah, the curve is going down. Yeah, let's go and have some party. No. The reporting is so bad. You don't report anything properly in India. So the curve, what's happening to the curve does not matter. So what this group did was, they had analyzed Indian scenario into a couple of things, and they said that the stable state of India will come somewhere around August. Third wave will be there in India. Why? Because India has vaccinated 5% of the population, which is 2.5 times UK. So the number of vaccines India has currently given is 2.5 times UK population, so India has actually vaccinated UK 2.5 times. So but third wave is mostly due to lack of responsibility of citizens. Even if you get the first dose, you still can transmit the disease. Even if you get the second dose, you can still transmit the disease. 85% disease we showed, right? See, 85% infection prevention. So 25% you can still transmit the disease. But after first dose, second dose, if people go around, so it's very difficult. But will the third wave be more towards children and all? No. No specific data has come out. So if some experts are saying, I don't know from where they are saying that, but no specific data has been fed to chess from where we get the data. This is like real data. I have the data for vaccines also, each and every data about vaccine efficacy and third trial data, every data I can see. No such data has come out for that.
I think it's mostly the newspaper reports and articles.
Yeah. I would again say, more than pandemic, it's the infodemic. So much of rubbish goes around. We have to be careful and we have to be responsible. And I think, yeah, we can blame everyone, but it's sometimes better to be more accountable. But yeah, I think no third wave for UK now, projected in September mid. No third wave for India right now. India right now has not recovered from the second wave. Third wave in India depends on the vaccination program. So yeah, likely there will be peaks, but it's not right to call it the third wave like that. And so yeah, it's a wait and watch and depends a lot on vaccination program and citizens. Thank you.
So like you said, the data reporting is not proper, but still I think the cases are going down, and the restrictions are slowly being lifted. So what do you think, up to what limit the restrictions should be there, or what kind of action should be taken?
For India or for UK? What are you saying? For India?
For India.
Yeah, in India, I don't have the exact data because I've actually withdrawn. So the cases are going down. I know that is for sure. I strongly believe that in India we need to have restrictions where the restrictions can be made feasible. For example, I currently do not see the point of opening up of malls. I just don't see the point. So you can say that, if you don't open up the malls, how will the shopkeepers survive? If you open up the malls, you open up the malls for restricted time. And for example, here, all zoos, everything are open in UK, but you just cannot visit because you have to book it. So everything is prior booked. In malls, you cannot prior book it. But what you can do is you need to encourage that if you can do something from home, you need to stay at home. So lockdown measures and curfews are very important, and they should still be in place. I strongly believe that. Vaccination program is going on. I think it's in full spread, and it should be encouraged and done, and unnecessarily crowding and parting. I'll tell you something, people see in India, what happens here, one thing is there. So when you have, let's say, a gathering, very, very simple, but this is what comes when you model things, and it becomes so tough. So let's take a very small example. Fuel stations. Yeah. Okay. So in UK, if you go to a fuel station, who gives the fuel to the car? Yourself. You go to the fuel station, you punch your card, you give the fuel, keep the fuel tank, you go out. In India, what will happen? You go to the fuel station, someone will say, hey, he will do it for you. He will take the card from you. So do you see how the disease is going? And this has been said that it's aerosol, so it's everywhere. So, so lockdown measures are very important because it is going to curb the small things. And also the domestic helps. The thing in India is you have domestic help. So we need to see how the disease propagates. Again, domestic helps. What does that mean? It means from one age group to another age group, one household to another household. So it goes from one household to another household. That's household spreads. So you can see that age group classification is so important. So if it spreads, it will spread. So it is important that you get vaccinated. But even if you get vaccinated, we cannot be a free floater because it is going to spread the disease. So I think in Bangalore, some of the places, I think there is still curfew and lockdown measures in place, which is extremely good. I think in Kolkata also it's there. In Delhi, I think things are opening up quite fast to my understanding, and what I did not expect that to happen. But even if lockdown measures the government is not doing, I think it is very important that citizens follow some restriction. I'll tell you something unique. So UK's target date is October 2023. Very simple. 80% of all trading nations will get 85% vaccinated. If you achieve this, then you can think of a scenario where you will be going back to normal, which was anyways not normal, and it will be a skewed normal. So 80% of trading nations, 80% vaccinated. Target date for UK is October 2023. Okay. So before that, there will be many restrictions coming and circuit breakers. So it's the same case with India, and it will be more tougher for India based on the dynamics and of the economy, the job sector, and yeah, everything.
So one last thing I just wanted to ask. In India, they are lifting restrictions based on the positivity rate.
Can you come again? Sorry, can you come again?
In India, they are lifting the restrictions based on the positivity rate.
Okay.
The test that they are doing and the positive cases that have come. So that's the positivity rate. But I think after listening to you, I think it should be based on the proportion of the vaccinations done. So the restrictions, the limitations of the lockdown should be based on the population that you have vaccinated.
Yeah.
Am I right?
Yeah.
I understand this.
Yeah, correct. I think what difficult situations with India is, since it's an informal economy, so we have a huge sector of people. For them, coronavirus is not important. For them, earning bread is important. You have to understand that for example, UK is a social welfare country. That means if you do not have a job, government will give you money to have vacations in Spain. You will have a very good house to stay. You can have Budweiser beer and sandwiches for dinner and lunch. Okay, it's a social welfare country. Who is paying that? We are paying. Our tax rates are about 40%. Okay, but in India, there is a huge sector. For them, coronavirus is not important. For them, they have to earn money to feed their family. Yeah. So what do you do with that sector? That's the issue. So it is very easy to say that we should do this, but there is also a different argument that, there might not be enough alternative applications which can take place if you do not lift the economy the way it is lifting. But what surprises me with the Indian scenario, and that what pains me, is the rules are broken by those who shouldn't break it. That is people like us. When we know that, this is such a state, so we need to be at home. We can be at home, but we don't. For example, I time and again said, in some of, I had some of argumentative clashes with Indian guys who are in India. We were in lockdown. We were sat at home from October 2020 to April 2021. India was not in such a huge lockdown mode. We were sat at home this whole period, which is incredibly wrong, and that in spite of the vaccination program going on. Hence, we are in the state right now. And still we have delayed it, which is a super good move. There were oppositions. Some fellows, some stupid fellows were arrested a couple of days back from the Birmingham University Hospital, which is also the biggest in the UK, the QE. They said that the criminal cases have been charged against them. So, so in UK, if we behave like this, imagine how difficult it is in India. But I think it is just a responsibility right now. And the mathematical models, I think TIFR, Tata Institute of Fundamental Research, we were collaborating with some for India help. I think they have done a super brilliant job, and their forecasts are also super strong. And they suggest that, it more depends on the transmission rate of urban age groups, which matters. So when I say urban age groups, that means what? Meeting in malls, partying. So that is playing a key role in India. And of course, hopefully the vaccination program in India, what can you do with the population? I think I think they have vaccinated 5%, which is 2.5 times UK. It's a bit tough. Thank you.
Thank you, Anand. Thank you.
Great question. Thank you.
Thank you, Abhishek, for asking some of the questions from which we would have asked. And thank you, Anand, for it. Why not, Subrat, why don't you go next and ask your question?
Yeah, hi, Professor Anand. My question is simple, and I'm sorry if it is, off the topic, but I just wanted to know your views that, given the recent developments, do you think that FOSSI is also involved in the Wuhan lab leak episode?
You're recording this session, huh?
Okay, we can drop this.
No. I'll answer this. I'm just thinking how to best put it. Okay, I'll answer this in a couple of ways. So your question can be, is COVID-2
man-made?
A lab product, man-made product. Okay.
Yes.
Now, Oxford has shown that there is no genetic accountability of the COVID. That means you cannot genetically trace it back. So if you cannot do that, then the situation of saying that COVID is man-made reduces. It is not. It doesn't cancel out, but it significantly reduces, and you cannot say that it is lab leak. Now, was it a lab leak? Let's analyze China. China is doing very great because there is no news coming out of it. What China did extremely wrong was to hide the data in COVID-19, right? December 19, November 19, to be very specific. So, in my opinion, I think this is not a full man-made product, but it has synthetic strains from the lab.
Right.
It was not intentionally lab leaked. Yeah. So there are synthetic strains which had lab interventions, but I don't believe that it was intentionally leaked. But what was intentionally done, which arises the question is, Why did they hide it? Yeah.
Right.
So yeah, I would say that they are to be blamed, but you cannot hold them to task, and you cannot do that, because it's very easy to say that we did not do it. And with studies from Oxford and all saying that there is no genetic strain which can be tracked back, traceable, so the potentiality of being lab leaked is significantly reduced, not taken off the shelf. So yes, synthetic implants might be there, but yeah, but there is again a difference between China and the rest. China is a military governed country, so if it's a house arrest, it's a house arrest. You just cannot go. You cannot just go and say, hey, sorry, police मुझे इस बार माफ कर दीजिए, please. You cannot do that. You will be shot. So China controlled it, and China is controlling it. Why do I know about China? I know a lot about what's happening in China because we have so much students from China. My PhD students are actually from China. So China is controlling it well. And you have to also understand one thing. For China, the government will tell you what they want to tell you. So,
yes.
So have you heard anything from China? I've heard nothing. So the government doesn't want to tell you anything. It doesn't. So yeah.
Yeah. Thank you. Thank you so much.
But one thing, Subrat, it has been an utter failure of WHO. Utter failure. I mean, this did not happen with Ebola. This did not happen with okay, I have a bit of distraction here. Miko, can you get Gugai away? Oh. Okay, close the door. Close the door. Sorry.
Yeah, so the retirement plum posting did all the damage at WHO, right?
Yeah, because I mean, see, when Ebola was spread, Ebola was more dangerous than this, and that time the lady was there, and how he managed it. You blocked the economy, and this guy has been put by the Chinese premier, and the Chinese premier's wife is also the ambassador of WHO, and it's just a sold out. I mean, right now what WHO is doing is good, but not incredible, and what WHO did initially was extremely bad. They did not even say that this is a pandemic. They refused to call it a pandemic, and China plays a key role, and you will be surprised to know that China plays such a big role in publications, especially in Lancet. It is incredible. So some of the things which you see, unless and until you see the data, with the data of the labs which are coming in, you're like, how can someone report this? Which is that they have got a very huge, they've got a huge hand, and it's from some other session, Subrat.
Right. Thank you.
Thank you.
Great. Any good words for India? If I will allow someone to ask that question, but before that, do you think any good words for India, like how things are? I know we have our own limitations here in India, unlike the UK. But what is your assessment in terms of what is being done is good, bad, ugly?
Why the second wave in India? Are you able to hear me? I'm getting.
Yes, we can.
Hello. Are you able to hear me?
Yes, we can.
Can you hear me?
Yes, we can hear you.
Can you hear me? Can someone say?
Yes, we can hear.
Yeah. Cool. Yeah. So why the second wave? The second wave in India is because of complacency by the authorities, both state and central governments. I will not be political here. And if something is wrong to me, it's wrong. Something is good to me, it's good. So there was a huge complacency in not only Indian citizens, but the Indian state governments and the central government. While we were locked down here from October,
everybody in India, many of my friends were roaming around in Goa, Maldives. Suddenly, everybody's going to Maldives. I don't know what's happening with Maldives there. So everything, and I have also heard that nobody cares about Corona. We have forgotten Corona, and well, you can see that people are dying in UK. You can see that Germany again went into a second wave. Take actions. I know someone very specifically who wrote number of emails and Twitter accounts and tweeters, which were not only rejected but also that doctor was threatened. He's a master in immunology. He's also a consultant hemato-oncologist. So there was a huge complacency error. Once the complacency error was hit and the second wave came, what India did was remarkable. There was oxygen, those things, and state governments were to be blamed. Vaccination, you can blame the central, but so once this was hit and people started dying, so people started realizing that my friends and families can die. I know almost everyone who has at least one known person dead because of COVID. It might be directly related to COVID or because of COVID. These are two separate things. So everybody had someone or the other known who has died. So when it hit everyone, then you see, oh wow, now this is a dangerous disease. We need to restrict ourselves. Government also came into actions, and yeah. But then suddenly something strange happened in India. When the whole world is saying, do not go for plasma, every day I hear plasma is required there, plasma is, no. The lobbying is so tough in India that the private sectors, because there is no healthcare sector in India. The healthcare system is so all over the place in India. So those are the severe constraints. But now, with the vaccination program on, and people realizing and people understanding that we need to take care of it. For example, I know, Rakesh, you had COVID, Suvrat had COVID. I know most of my friends who have had COVID, Inder had COVID. So with the system requirement clear, that we need oxygen, we need the vaccine, with the system requirement clear, and people right now going and taking the vaccine, some apps are there, the apps are getting loaded. Why? Because of the traffic, but with the systems in place and the projections clearly showing that vaccination is the only way to get out of it. Vaccination is the only way to get out of it. Nothing else. Herd immunity will not work. Population immunity will not work. I've shown you the data. This data has been fed to the UK government. They also know it won't work. Vaccination is the only way to get out of it. Now, once this is clear, I think India is in a much more stable place, and we have projected stability mid-August. So India will be in a much more stable place in mid-August. We have also taken the vaccination propagation of India. So I think by mid-August, India will be in a much more stable place. The only thing which is important for India is we need to be a bit of self-constraint. I cannot tell you how important is that. Even if you get the first dose, we need to restrict ourselves. Even if you get the second dose, we should, unless and until everybody gets it. So I think with the system requirements understood, that vaccination is key, and you have now the supplies of oxygen and the vaccination, everything is coming in. I think India is in a much better place, and every day it is improving. Every day it is improving. Specifically, if you see what happened to India a couple of months back, which was very sad. I feel very sad, and what can I say? You can say I'm here, but my heart is still. So yeah, I have got good hopes with India. Mid-August things will be shining up. Third wave, I've already answered Abhishek's question regarding third wave. But yeah, thank you, Rakesh.
Thank you, Anand. We'll just take one last question, and the Pine, why don't you just unmute yourself and ask your question? Rest other questions can be directed to Anand's email. I have posted that in the chat. So if any other questions can be emailed to him directly, and he would be happy to answer it. I have taken that liberty, Anand, on your behalf.
Yeah.
Thank you, Nando. It was very insightful of you to share the work that you've been doing. And as time is a constraint, I will just point directly to the question. Your mathematical model shows when this pandemic is going to subside, or this is a new normal and the world will be like this for a long duration in time?
Good question. Okay, let me answer your question relating to another study which I'm involved in, that is known as a long COVID study. So what is a long COVID study? Long COVID study is, as the word suggests, long COVID, you are vaccinated. And then how your body dynamics works and what happens with your immunity, with your transmission of the disease if you get again and again exposed to it. Especially this study is one of the biggest studies in UK, which is on the doctors specifically, because they are getting exposed again and again. So I don't believe that this is a new normal. I mean, new normal in terms of norms, yes, maybe we are going to, the kids, I don't know, will especially the younger ones which are being born now, when they are going to again see a mask-free world, even though they are not wearing masks, because you don't have to wear mask till year 8 in UK. Year 8 means class 8 in India. Yeah. So those are those are new norms from the well-care part of it, so you need to wear masks, you need to sanitize your hand. I must tell you that in UK it is very less followed, to be very frank. But COVID is going to stay. Vaccinations have come up. There can be repeated jabs. The things are going to get back to where it was from economical perspective and livelihood perspective. I would suggest, as I said, it's October 2023 for UK. Traveling and all will come up like as it is. But COVID is a virus which is going to stay for some time, unless and until as I said, 80% of the trading nations get 85% vaccinated. So now this is a local problem which needs to be maximized. So this is not a global problem, but for each local problem, it has to be maximized. But since there are international flights and international travels, so this local problem is actually a global objective function. So 80% resignations get 85% vaccinated. You can think about having things back to pre-COVID standards with an improved, what should I say, understanding of what might happen if one is not disciplined. So yeah, but yeah, COVID is going to stay for some time. It will not impact. Deaths are going to reduce because we are understanding more and more about it. Very upsetting and sorry to hear so many unfortunate stories in India and in UK. I hear them every often. My wife is a doctor, so I hear so many wrong things, but everything goes for an experience and understanding. So yeah, I would say.
Can you give a number? When? 5 years, 10 years?
No, as I said, for UK, I still believe it's Q1 2024. It's going to be the behind worrying of COVID. So hindsight, I'm going to say there was COVID. So Q1 2024, I'm going to look back and say, okay, there was COVID and we did that. So for India also, I would say somewhere around 2024, 2025. It depends clearly on the vaccination programs. So I would take it as 2024, Q1, Q2. To think of COVID as a hindsight problem, not an ongoing problem or a forecasting problem, So that is important. So if I'm here, so this problem is my hindsight. I mean, looking back, not my forecasting problem. So I would say Q1, Q2, 2024. Yeah. Not the deaths and all, they will decline, but the overall pandemic problems with economy and all the things. That does.
Yeah. I have many questions, but I won't take much. Okay.
No, you can ask if I'm whatever. I mean, I don't know what's the. Yeah, Subrat, I just want to thank you for the platform. I think this platform is provided by you. I forgot to thank you earlier. Yeah.
Great, Anand. Thank you for your time, and thank you, participants. It has been actually, we have extended it for quite long, unlike the previous adults. So yes, certainly some insightful discussions that came out. And I'll just speak just one word. Thank you, Anand.
Yeah, someone wanted my mobile number, so I've just shared it. Oh, I forgot to add the +44. Just add +44 in front of it. Okay. Yeah, a WhatsApp number, whatever. Yeah. So, oh, sorry. Just one sec. Just give me 1 sec to everyone. I'll just do that. Okay, thank you everybody. Thank you guys. I think it was wonderful. I did not think that I'll talk so much. But yeah, thank you. Thanks to the team, and thank you everyone. It's really wonderful to be a part of this alumni. It makes me very happy. And enjoy and stay safe, and hopefully we can meet we can meet in December. I still keep my fingers crossed. So yeah, thank you. Thank you for joining, guys. Yeah, bye and